Good morning, everyone. How are we today? I'm just gonna flip a couple people over really quick. Here we go. Now, welcome and thank you for attending this morning's vertical integration session. We have Telehealth in Australian General Practice. What have we learned from GP registrars? We are joined today by Dr. Katie Fisher, who is a GP researcher with RACGP, as well as our beautiful committee, which you'll see shortly. My name is Sydney Cruikshank. For those of you who haven't met me, I'm one of the PHN education officers on the Central Coast. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. Like I said, on the Central Coast, that's Darkinjin land. And I'd also like to pay respect to elders past, present, and emerging. So a few things to let you know about this session. So you come into the session automatically with your camera and microphone disabled. I'll slowly switch you all over and that will give you full access. So if you'd like to turn on your camera, please feel free. Or if after the presentation you want to come and ask any questions. We also have the chat function located within your control panel. If you have any questions throughout, just pop them down. Katie knows where it is as well, so she'll be looking in case there's any pressing questions to answer, as well as Georgia, she'll be looking at them too. Now, the evaluation will come to you after the session automatically, so if you can fill that in, it's so important just because it enables us to renew this program, which is our main goal for the new financial year. Also wanted to give a couple of shout outs to the last few winners of our $50 Prezi voucher. So we give vouchers every session for those that participate. Wow us, do different things. So we had Kelly, Alma, Sabashi, Sarah, and then Jack last session. So thank you to all for all your contributions. Now I will hand it over to Dr. Fisher. Thanks, Katie.
Thank you. Thanks. Hi, everyone. So I'm Katie. I'm a GP working up here in Newcastle, and I'm also a GP researcher part-time at the RACGP in the Training Research Department. So this topic today, telehealth in Australian general practice, this came from my GP academic post that I did as a registrar. So a little bit of background for those that aren't familiar with that particular post. It's actually an extended skills term that you can do part-time for 12 months, and you're affiliated with the university and you get a bit of a split of a research project as well as teaching in the university as well. So for my project, I was sort of brainstorming ideas, and it was around the sort of mid to late 2020 when I was thinking of this research project. And telehealth kind of fell into my lap. I was quite lucky that it was sort of new and had come in around that time, and we were collecting data on it already through the recent project, which I'm sure any GP registrars here today are very acutely aware of recent, but I'll talk a little bit about that later on in the methods section as well. So that was kind of how this project came to be. And I'm going to split the time between talking a little bit about the research project and the findings, but then also spending a little bit of time later on talking about the art of the remote physical examination now that we're continuing to do telehealth in our general practice work. So I guess first of all, why telehealth? Pre-2020, while lots of GPs were still performing a form of telehealth, it wasn't, I guess, formally recognised as general practice work, and it wasn't remunerated, so GPs weren't paid for that time. So while it was really common for GPs to pick up the phone, call their patients, discuss results, that was all in unpaid time. And there were only sort of limited telehealth item numbers that were available, mostly for specialists, but also for some GPs doing sort of case conferencing, particularly for patients in rural and remote areas. So it wasn't really very widely recognised. And then with 2020, with the COVID-19 pandemic, we obviously had a really rapid rollout of telehealth, both phone and video conference. And we didn't really get a whole lot of warning for that. And we had to adapt really quickly, and I think for GP registrars especially, that was particularly challenging because you're already trying to learn the ropes of general practice, and then to be thrown in the deep end and have to learn how to do telehealth as well was really hard. And that kind of stemmed from my own experience as a Term 1 in 2020. So I actually started my GP training in 2020. And that was really challenging. I think we got maybe 3 or 4 weeks of sort of normalcy before the pandemic was declared, telehealth was brought in, and you really had to kind of learn everything on the fly. So that was really challenging. And obviously lots of practices weren't equipped for telehealth, so we didn't have the infrastructure with webcams, reliable broadband to be able to do video conferencing. So it was all very new. And we didn't really have a whole lot of knowledge on how this would impact GP training. So those are some other questions that came up around that time as well, kind of separate to my project, but I'll talk a little bit about those later on. And then, like I said, I think one of the most challenging things for me as a registrar at that time was physical examination via telehealth. So often patients would call up with things that I felt like I really needed to see face to face. And I didn't really realise how much physical exam can be done, at least via video conferencing. And some of that came up during my literature reviews, and I kind of want to share some of that with you guys today as well. So this project wouldn't have been possible without RECENT. For those that aren't aware of what RECENT is, it's called the Registrars Clinical Encounters in Training Project. And essentially GP registrars during their training across a few states, New South Wales, the ACT, Victoria and Tasmania at the moment, they record 60 consecutive consultations of patients they're seeing in the practice during each 6-month term for a total of 3 terms. This was originally designed as a reflective tool for registrars. So at the end of each term, registrars are sent out a feedback report, and you can kind of see what kinds of things that you're seeing in general practice and compare that to what your peers are seeing, and also to BEACH data. So BEACH was a previous study that looked at fellow GPs and the kinds of things they were seeing in their practice. So it gives you a bit of a tool to compare yourself to others and see, am I getting that breadth of clinical exposure and experience I need as a GP, and what things am I not seeing, and that kind of thing. But the other side of RECENT is also being able to design research questions and research projects to help sort of improve and inform the GP training program. And so there's a number of details or variables that we record in RECENT. The first part is the clinical aspect of the consultation. So what are the patient demographics? What were the problems that they came in for? What was the management? So what tests did the registrar order? What was the management? Did they organise follow-up? Those kinds of things. But we also get to see the educational components as well, which are really important for a GP training perspective. So how often was the registrar recalling the supervisor into the room for support? How often were they creating a learning goal? And by a learning goal, I mean they've seen something in the room and gone, I want to write that down and look into that later on. That's something I want to actually study a bit further. So those are the kinds of things that we record. And I was very fortunate that Medicare item numbers also get recorded. So I was able to split consults into face-to-face, phone and video to be able to kind of look at this research question. So the question, or the aim for me, was looking at the prevalence. So how often a GP registrar is doing telehealth, and what are the associations of telehealth versus face-to-face? What's different and what's similar about those different modalities of healthcare? So for the methods, I looked over an 18-month period from term 1 2020 to term 1 2021. And like I said, at that time and even now, we've got registrars participating from New South Wales, the ACT, Tasmania and Eastern Victoria, so not all of Victoria at this stage. And we performed univariable and multivariable logistic regression, and the outcome factor was whether the consult was telehealth, so phone or video conference, or face-to-face. I've since gone on to do another study just looking at phone versus video directly. I won't be touching too much on that today, but we were able to kind of look at both research questions during my academic post. So for our results, so we had, you can see here, just under 1,200 GP registrars who recorded just over 102,000 consultations. And of those consultations, just a bit over 21% were via telehealth. And if we break down that telehealth into phone versus video, you can see that overwhelmingly the majority of that was via phone, so only 3% via video conference, which I think makes a lot of sense. It's fairly intuitive given that this was sort of not long after telehealth had been introduced, and a lot of practices weren't set up with the infrastructure to be able to do video conferencing, but also patients had never really done video conferencing with a doctor before, and a lot of our patients weren't set up to use those platforms either. So I think this finding is relatively intuitive. However, it doesn't really seem to have increased a great deal now when you look at the Medicare statistics. So video conferencing is still quite low in terms of uptake, and I'll talk a little bit more about that in a couple of slides' time. And then looking at how telehealth differed to face-to-face, first of all, we found that telehealth was shorter on average. So telehealth consults on average lasted 13 minutes, whereas face-to-face were 19 minutes. And then in terms of problems that were addressed during the consultation, for telehealth, that was 1.3 on average, and for face-to-face, that was 1.5. That might not sound like a really big difference, 1.3 versus 1.5, but when we looked at that in our multivariable analysis, it was statistically significant between the two. So it tells us that telehealth is shorter and we're addressing fewer problems in those consultations. And then an interesting finding from the, I guess, educational side of things is that we found that in telehealth, registrars were much less likely to seek their supervisor for support. And this might be for a number of reasons. I know from my own experiences, it was quite challenging when I was on the phone with a patient and my supervisor was on the phone with a patient. It was really hard to try and figure out how to get them into the room or bring them into that phone call. Whereas when we were all doing face-to-face and you just had a patient in the room, it was relatively easy to call the supervisor and go, can you come in and look at this? Or knock on their door and say, would you mind popping into my room for a few moments? It was definitely a lot more challenging logistically when we were all doing telehealth. So that might explain why registrars were less likely to have supervisor input during those telehealth consultations. So then I've broken up some of these associations into positive and negative, meaning positive associations were things that we were more likely to see with telehealth compared to face-to-face, and then the negative associations were things that were less likely via telehealth or more likely via face-to-face. So for the positive associations, we found that telehealth was associated with female patients compared to male patients. Existing patients, so that's patients that were already known to the practice or already known to the registrar themselves. And this is probably partially explained by some of the legislative requirements around telehealth at the time. So a lot of people would be familiar with the 12-month rule where the patient had to have been seen face-to-face in the clinic 12 months within that last 12-month period to be able to access telehealth. So those rules about who could use telehealth changed sort of mid-pandemic. Existing problems were associated with telehealth, so it was more common for a registrar to use telehealth for an old problem or a problem that was chronic as opposed to a new problem, which I think also makes a lot of sense. It's a lot easier to manage kind of, I guess, a chronic disease that you've been monitoring for a long time remotely than, for example, a new musculoskeletal injury or something that you would want to see face-to-face. And then registrars were more likely to generate learning goals during telehealth consultations. Now, this finding I thought was quite interesting because on the one hand, you've got registrars less likely to access supervisors during telehealth, but then on the other hand, more likely to generate learning goals. So that was a really interesting educational finding, and that kind of sprouted a few more research questions about, well, how is telehealth actually impacting registrar training and learning? Is it affecting the kinds of consultations that they're seeing? And I'll talk a little bit more about that in the next couple of slides. And then for telehealth, follow-up was more likely to be arranged. And again, I think this is fairly intuitive as well. I remember at that time, a lot of practices, we were kind of only doing telehealth, trying to keep everyone at home. And then we were kind of almost using telehealth as a triage to decide who needs to come in and be seen face-to-face versus who can we just manage over the phone. So I think that higher rates of follow-up probably were within that pandemic context of trying to get everyone to isolate and stay home. But it does raise some questions about service availability. If we're kind of doubling up and doing 2 appointments for one issue, how is that going to impact workforce and availability of appointments for patients? And it'll be interesting to see how that's changed now that we're moving into a bit of a sort of
Katie, I have lost you. All right, sounds good. Thanks, Katie. Georgia, are you there?
Yes, I am. Oh,
Okay, perfect. I was like thinking, I'm like, did I touch something? Where'd she go? Is it just me? So, so if you want to fill it in with anything while we're waiting.
No worries. I'll just try and find out where my camera is as well. So I'm just getting used to this format. Hi, everyone.
There we go. There you are, Katie.
Sorry about that. This is a great example of why telehealth was so hard, is that internet drops out and then you can't do what you need to do. All right, let me share my screen again. Okay, is that kind of working now? Can you see that okay?
I don't see your screen yet.
Okay.
Let me just, let's see. Okay, try it now and see how you go.
I might just move the chat across very quickly before I do that.
There we go. We've got your screen and we just want to put it in slideshow.
All right, how's that?
Amazing. You're all good. Perfect.
Great. All right, where did I get up to before I cut out? I think I probably was in the positive associations, maybe going through those a little bit. So I might move on to the negative associations. So the extremes of age, less than 15, greater than 64-year-old populations, less likely to use telehealth or less likely to be seen by registrars when they were using telehealth. Culturally and linguistically diverse populations and also Aboriginal and or Torres Strait Islander populations, they were more likely to be seen face-to-face by registrars rather than by telehealth. So that raises some implications about equitable use and access to telehealth. And this has been seen not just in Australia, but also internationally, that certain groups have less access to telehealth or appear to have less access. So I guess it raises questions for our policymakers about how can we make telehealth more accessible to all groups. And I think part of some of these findings may be things like hearing impairments, for example, in the elderly, or lack of access to a digital device with a webcam, or, you know, sort of the, I guess, understanding of how to use telehealth platforms. Although, given that only 3% of our telehealth consultations were via video conference, we can assume that the majority were via phone. So most people have access to a phone. So it's still interesting that despite that, we were seeing a lot less of those extremes of age via telehealth. And then looking at investigations. So interestingly, one of our hypotheses going into this study was that, well, we think telehealth is going to be used really commonly for repeat prescriptions. You know, that's something that can be done relatively easily over the phone. But actually, we were seeing that medications were prescribed more commonly in face-to-face appointments versus telehealth. So that was an interesting finding. And then lastly there, registrars were less likely to order investigations, so things like blood tests and imaging via telehealth. That was more common in face-to-face, which again probably makes a bit of sense in that if there's something that's new that the patient's presenting with, you're probably going to want to assess them face-to-face before you decide what investigations are appropriate to order. So those were some of the findings from the multivariable analyses. There were lots of different, I guess, significant or positive sort of findings, but I don't have a whole lot of time to go into them in too much detail today. So I'm just going to focus on sort of a few things. But firstly, I want to quickly show this graph, and I hope it's big enough that you guys can see that. But essentially what we're able to do with the recent data when we're coding the reason for the presentation or the problem that the patients come in with is we can code that into what's called a disease chapter. So the ICPC is the International Classification of Primary Care. It's just a coding system. And you can see that I've put all the chapters there along sort of the bottom, and it sort of roughly codes things into kind of medical specialties. So you've got things like eye, ear, cardiovascular, digestive, etc. The blue bars there are face-to-face, or the percentage of consultations that were done face-to-face from those different chapters, and then also the orange bar is telehealth. So this gives us a bit of a snapshot view of what things were sort of more commonly seen via telehealth versus face-to-face. And it's probably not surprising that the respiratory presentations were much more sort of commonly seen via telehealth, especially given that we were encouraging people with any kind of respiratory symptoms to isolate and stay home. But then you've got other things like eye, ear, musculoskeletal, skin that were more likely to be seen via face-to-face, which again makes a lot of sense. Those particular systems are quite difficult to examine via telehealth and certainly via phone. So the key messages or the key takeaways from this project, I think the first one is that there was a low uptake of video conferencing, less than 4% of our telehealth consultations, and that uptake in the nationwide Medicare statistics continues to be quite low. So it raises this question of how can we increase the uptake of video conferencing? You know, there's a lot of sort of reported benefits to telehealth, but compared to phone, you can observe the patient, you can observe their surroundings, you can do a limited remote physical examination with them. So how can we increase that uptake? So for policymakers, that's considering, you know, do we need to think about funding and grants? I know some local health districts and PHNs have offered this to general practices to try and increase uptake of their digital infrastructure. So having things like webcams so that the GPs can do video conferencing, the platforms for video conferencing, because they often have a subscription fee to be able to use certain video health platforms. So thinking about funding for practices to be able to increase that, but also thinking about the patient context as well, because it's all well and good if we have a webcam and we have the broadband and the telehealth platform, but if the patient doesn't have a reliable broadband connection, and if they don't have a device with a webcam, they're still not going to be able to participate in telehealth consultations. And that's going to be particularly a barrier for those living in rural and remote areas, particularly where internet and broadband connectivity can be quite poor. So it's about thinking about ways that we can work around that. I know in the United States, they had these things called telehealth hubs, where for people living in more sort of rural and regional areas, there would be sort of a central hub or a location similar to a GP practice where patients could go. There would usually be like a nurse or at least a medical assistant available to do some vital signs or OBS first, and then the patient would go and sit down in their room, have their video consultation with their doctor, and then be able to go home. And that kind of took away that barrier for patients, in that the telehealth hub provided all the technology and the internet. So there's a few, I guess, possible things that policymakers could look at to try and increase that uptake. The second key message here, that telehealth tends to be shorter but with higher rates of follow-up. Now that was pandemic specific, so that may have just been within the context of trying to keep our patients at home and not come into the practice. And it would be interesting to revisit a similar research question now to see, is that still the case? I know for me personally, I find that it can be really challenging when it's a new problem and it's something that I need to see face to face. It's very hard to manage that via telehealth, and I will often have to rebook the patient for a face to face or bring them back into the practice. So there is that kind of double handling of the one problem, which then reduces the available appointments and has implications for service availability. And I know, I'm sure it's the same on the Central Coast, but I know lots of our GPs here are already kind of overrun and have very little time as it is. So having to use more than one appointment for a new problem is really challenging. And then the third take-home message here is that from a registrar training or GP training perspective, registrars less likely to seek supervisor support during telehealth, which may be due to the logistical challenges of doing that, but more likely to generate learning goals. So this prompted this question of, well, how has this impacted their training? And what we actually did last year was a qualitative study that looked at how telehealth impacted registrar education and training. And some of you may have seen emails go out for invitations for interviews last year. So we've wrapped that study up, and we're currently in the process of writing up those findings to publish. But there were some really interesting things that came out of that. And even though our question was specifically how did telehealth impact training, as you can imagine, we kind of got answers about how did the pandemic more broadly affect training. And some of the really big things that we heard again and again in those interviews with registrars was I didn't get procedural skills exposure. I didn't get as much as I would have pre-pandemic because patients weren't coming into the practice, and I wasn't getting as much sort of physical examination practice, which was quite challenging for a lot of registrars who were trying to study for their clinical exams. So lack of physical exam, lack of procedural skills, those were the really big barriers with telehealth and with the pandemic more broadly. I've popped in the details from this particular study. So we have published one paper from this study already in Family Practice if you wanted to have a look at that one, and the phone versus video sort of sub-analysis, that one's currently also under review and hopefully will be published later this year as well. So I was going to then move on and talk a little bit about the remote physical exam, but happy to take any questions about the first half of this talk, so about the research project, if anyone had any questions about that at the moment.
Feel free to unmute yourself as well, guys, if you'd like to do it, or just pop it in the chat box. And if nothing comes through, Dr. Fisher will just move on to the next topic.
Yeah, there's no questions in the question box, so I think you're free to continue. Thank you, Katie.
No worries. All right, I will keep going. Let me pop my chat over here. All right. So the concept of the remote physical exam is relatively novel. It's certainly not something that I had ever heard of before, and not even as a registrar. And I wouldn't imagine it's something that universities are routinely teaching as part of their clinical skills training. So I think it's something that's kind of new, that's come out of the pandemic. But this idea of sort of the art of doing a physical exam via a video conference platform. And initially, I have to admit, I was kind of more of a skeptic. I was of the kind of group of people that said, well, you can't do a physical exam via telehealth. That's nonsense. You need to actually bring the patient in. You can't do any of that. But there's surprisingly quite a lot that you can do via video conference. And a big part of that is using the patient as kind of your hands and coaching them through doing an examination on themselves. And it's surprisingly effective being able to use the patient to, in that way to do that physical exam. So I wanted to show just a brief video that I kind of stumbled across in my literature review for this project, which I thought was a really succinct, it's a 5-minute sort of summary of things that you can do via telehealth. And I found that really useful, and then I'll kind of talk a little bit more after that. I'm hoping this is going to work with my internet, but let's see.
Hi, I'm Dr. Tanya Elliott, and I'm going to walk you through how to do a physical examination through telemedicine. So it was William Osler that said that medicine is all about the art of observation. So the first thing I do after I connect with the patient and consent them to do the video consultation is evaluate their general appearance. Are they ill appearing? Do they have pallor? Are they diaphoretic? Are they flushed? Then if I feel like I need vital signs, I ask them if they have a thermometer at home, and just to go ahead and take their temperature to show me what the reading is, and then I can document what the result is. Some patients also have a home blood pressure cuff, so that's another thing I'll ask them to go ahead and get to take their blood pressure and pulse if it's relevant. If patients don't have one and there's somebody that you see chronically and you'd like to have that as a regular vital sign, you can just ask them to go ahead and pick up a straightforward blood pressure cuff and then show you the result on the reading, and you can document that. Respiratory rate is something that you can calculate as the patient is speaking with you. Next, let's do the head, ears, eyes, nose, and throat examination. So is the head normocephalic and atraumatic? Next, look at the eyes. Are the pupils equal and reactive to light? You can ask them to look up, down, to their left, to their right, diagonally. And with that, you're also documenting aspects of a neurologic exam. You can actually do a cranial nerve exam as well, with the exception of the olfactory nerve, which is often also deferred in the office as well. If you want to look in the back of the throat, have them open their mouth, stick out their tongue, and do a big ah into the camera. If for some reason you can't see, you can ask them if they're on their smartphone to just adjust their angle. I also sometimes will ask patients to grab a flashlight or use a flashlight on their smartphone to be able to see down into the back of their throat. We can also evaluate the sinuses. I tell my patients, okay, now you are going to be my hands for me. Take 2 fingers, tap here, and let me know if there's any pain. Use a moderate amount of pressure. Same thing here and here. Let me know if there's any pain or any difference on either side. And then I can document whether or not there's any maxillary or frontal sinus tenderness. Now again, the only difference then when they're in the office with you is the patient is being your hands for you, but the response is still subjective, and you can document that on your physical examination. The next thing I ask patients to do if I'm concerned and I need to evaluate for lymphadenopathy is I teach them where the sternocleidomastoid is on either side of the neck. Take 2 fingers or 1 finger, depending on how big their hand is, and feel for something that's pea-sized or greater down the anterior and posterior chain. Now, sometimes patients get this, sometimes they don't. However, if it is a large lymph node, they should be able to feel it, and then they can actually show you exactly where it is and whether or not they can grab onto it, whether it appears to be mobile or fixed. I also will ask them to feel here and here to evaluate whether or not there's any submandibular tenderness. The next piece is the respiratory exam. Now, a lot of times doctors will say to me, well, you can't do the respiratory exam because you don't have a stethoscope. Well, there are aspects of the respiratory exam that you can do through a video visit without a stethoscope. So first thing I do is ask my patients, take a big deep breath. Now, I see whether or not they're coughing in the middle of that. I see whether or not there's an expiratory wheeze, whether or not that's relevant for you and in the context of the patient. I also evaluate whether or not the patient is using any accessory respiratory muscles for breathing, nasal flaring, use of any neck muscles, any paradoxical breathing where the abdomen is moving differently from the way that the chest is moving. And then all of that can be documented. The next part of this video series, I'll walk you through how to do.
So I remember when I stumbled across this, I thought that video was really interesting, and it kind of opened my eyes a little bit to the range of things that we can do via video. And obviously we don't need to do all of those things every consultation. We can kind of tailor it to what we need. But I think it's a great example of how much we can do with video. And I think if it's not clear when we're doing the video conference call in terms of looking at the back of the throat or looking at a rash, I mean, most patients can take a photo on their phones and email that through to us as well. So there's kind of ways to work around that. This was a paper called the Telehealth 10 that I had a look at when I was doing my literature search, and it was also a nice sort of summary of the different aspects of a remote physical exam that we can do, and a few other things listed there that were not in the video. So things like abdominal exams, so getting the patient to feel their abdomen and tell us whether it's firm, whether it's tender. Neurological exams, so as the presenter said from the YouTube video, you can do pretty much a full cranial nerve exam via telehealth, but you could also get them to put their phone down and demonstrate their gait and sort of their sit to stand and things like that as well. So I think there's lots of things that we can kind of do remotely now. And then this Tydo Care here, this is something that I'm not affiliated with in any way. It's an American-based service, but I came across this when I was writing up my papers, and I thought this was a really interesting concept. But essentially, it's a subscription-based service, from my understanding, in the US, where you sign up to it, you get this equipment sent out, and then you can kind of use it for remote or telehealth consultations with a doctor. And you can see that in the photo here, they're demonstrating the tongue depressor attachment, and you can either do a live feed on this particular device to the doctor, or you can take photos and send it through. And then some of the other attachments down here, there's an otoscopy piece that can be put into the ear. And again, you can either live feed that, and then the doctor can kind of give advice about, how to adjust it to try and see the tympanic membrane, or you can take photos and send them through. And then this one in the middle is a few different things. It can be used as a microphone for auscultation. And this is what I thought was really interesting, because I think the biggest barrier is not being able to auscultate the heart or the lungs during a telehealth. But with this device, supposedly you're able to, and it kind of shows the patient on the monitor where to place that device for heart auscultation and for lungs. And you can then hear, the heartbeat, and you can hear the breath sounds through that device. And it can also be used as a thermometer, a forehead thermometer as well. So I thought this was interesting and maybe a sign of where telehealth might go in the future here in Australia. It might become a lot more common to do a lot more via telehealth, but I guess we'll have to wait and see what unfolds. So I think that is the end of my slides. So if anyone has any questions, happy to take them.
Can I ask a question? Can you hear me?
I can.
You can. Okay, I'm on my iPad. It's sort of unfamiliar to me. So thanks for that very much, Katie. That was really great. I recently did a telehealth course. The reason I did it, a physical examination telehealth course. The reason I did it was because our PHN in Northern Sydney is moving to doing telehealth in residential aged care. And I have a few patients in resi care. And it's going to be with an iPad and a nurse holding it. So I thought, well, you know, I do actually examine patients, even when they're older. Not everyone worries about that, but that you can pick up such a lot from examining people. So I thought I'd see how that might work. So I did this telehealth course with Akram, the physical examination stuff, and it was quite extensive and really good. And it's amazing what you can do. Even, you know, I could see, I know every chink of the presenter's mouth, and he also pointed out pulling back the cheek in different ways so you could see the dentition and so on. But one of the things he said was, make sure that you document any limitations in your physical examination done by the patient. For example, they may not be able to pull back their cheek, or on palpation of the abdomen, and he did demonstrate that, standing and then lying. He said sometimes they don't want to press too hard if it's painful, so you need to document that. So I just thought that was an interesting tip out of that.
Yeah.
It's a really interesting area. I think it's amazing.
Yeah. And the TytoCare thing too, that came up because one of the reviewers for one of our papers was aware they were trialling that in nursing homes in Canberra, actually. So they were trialling that equipment and that model of care. And I haven't seen the study from that trial yet, but I wonder whether that's something that will be rolled out into more nursing homes going forward. That'd be really interesting to see.
Well, it's seen as a solution to us visiting nursing homes, especially during outbreaks, but they're having a shortage of doctors and that's causing a problem. So, so it could work. I haven't tried it actually in the nursing home yet. I've offered and there's been a resounding silence from the nursing homes. So. Even though I know they've got an iPad because my patient's got an iPad that the Dementia Behaviour Management Advisory Service gave her. So I know they've got one, but that I think was a step too far for them at the moment.
Yeah, and that's a big thing I think too that came up in the literature was that familiarity with the technology and whether or not patients and doctors were ready to adopt that in their everyday practice, because obviously there's a big learning curve that comes with trialing something new. So yeah, I think that'll be a big hurdle to overcome.
Yeah.
Thanks, Dimity.
Okay, that was great insight, and it was something we'll all be thrown into the deep end and in 2020, and it's something again we haven't had much training in. We just have to sort of wing it and make it up as we go along. So even that from that video, I've got lots of tips. But when I was in Dubbo, I think mid-COVID break, it was in 21, I went to the Royal Australian Flying Doctors, and they've been doing this for years with examination and with remote communities. And I was just reading it, going, oh, you know, they've been doing it for years, and here we are. What do we do? But I still find the video really useful, especially with EMTs and diagnosing tonsillitis, and yeah, that was great. Just interesting what video platforms people have been using as well. And was that listed in the study too, what video platforms we use?
Yeah, we didn't collect data on the video platforms that people were using at the time, but I recall personally, I think we went through 3 or 4 different platforms in our practice here before we found one that we were kind of happy with. And I think it was difficult too, wasn't it? Because a lot of them were free or were funded during the pandemic, and then once that ended, it was suddenly an extra cost for practices on top of all the other costs that were piling up. So I think I feel like there's a lot of work still to be done in terms of funding it appropriately and making sure it's accessible for everyone, because there are a lot of costs, I guess, to running that and having the equipment and internet capability to support it.
Yeah, we tried quite a few platforms as well, and I think we did GP consults, which was free and now it's at a cost, and with our online booking, there's a video that's through HotDoc, and that seems quite good as well. But and just another comment is, I suppose, the expectations of the patients of what we can do over the phone as well. And you mentioned obviously there's problems managed over the phone, but it's amazing what people think you can do over the phone. And also the locations of where they are, that there might be, they've been speaking to patients in the room cupboard at work, so they're working for childcare and they want to go somewhere quiet.
Excuse me, Georgia. Do you have a headset by any chance? Because your audio is very robotic this morning to all of us.
Oh, sorry, I don't have one with me today, sorry.
That's why I was like, I wasn't sure if it was just me or anyone else, but then Kelly said it as well. So I'm like, okay, it's not just me. And then Ruben also sent through saying that the telehealth can be helpful in burns assessment and cardiac failure.
Can I interrupt you, Georgia? I'm Ruben. I'm a GP in Erina. I have worked in 7 years in managing rural emergency departments, and when I have burns patients, the specialists from Tamworth and Dabo are able to watch the burns patient and give me assessment. This is in extensive burns of children and adults. But if you have a burns patient at home and you are doing a video call and it's only a small area or whatever, and they don't need to go to hospital, you can use the video conferencing to see the assessment of burns, and you can even ask them to touch with a pin and see whether it's a superficial burn or a deep burn, and you can tell them to use silverdiazine, whether you want to decide on antibiotics and all that sort of thing. So it can be very helpful in burns assessment. The other thing is, I used to treat severe heart failure patients in the emergency departments with specialist help from emergency physicians, help from Tamworth. And of course, they are watching me for half an hour, 45 minutes in an interrupted fashion, telling me what infusions to give to manage the heart failure. But let's say a mild heart failure patient is at home and she's doing a video conference. You can always see ankle edema. You can always get her to show the neck and see whether the JVP is raised. You can ask her to, if she has a bathroom scale, you can ask her to check her weight. And if you have a pre-weight of 74 kilos 4 weeks ago, and now the weight is 76 kilos, then you can start judging, is there a mild heart failure going on? There's a plethora of information to gain from video conferencing. And thanks for showing that video from the US. It was also, fairly illuminating. Thanks. Thanks, Georgia. And thanks, Katie.
Thanks, Ruben. Yeah, I think it definitely has a lot of potential, doesn't it, to make things, I guess, more convenient for the patient, keep them at home when they can be kept at home, make sure that we're kind of optimizing service availability in the emergency departments as well as general practice by keeping those things at home that can be managed at home. So I think there's definitely a lot of potential there. It's just about, I think, as Georgia was saying, it's tricky sometimes managing some things by the phone, particularly if patient expectations are a tad unrealistic. So it's how do we optimize that and decide who is appropriate for telehealth and who isn't? I think that's something I've really struggled with in my own practice is how do you train your patients to know what's appropriate for telehealth and what's not, because you can't stop them from booking a telehealth for an ankle sprain or for a musculoskeletal injury that really needs to be probably assessed face to face. So I think that's one of the hardest things is training the patients up and triage of face to face versus telehealth.
And I know we try and keep a few appointments at the end of the day just in case we have a telehealth earlier on and we need to bring them in, because if you're completely booked out, it's like, oh, where do I see you? So yeah, we've had to adapt in that way as well. Any other questions? And you can unmute. It's nice to hear your voice. You can turn your camera off. It's nice to see your face too. And it might even be your biggest win on a telehealth or a video call, something that you've diagnosed that might have surprised you.
Then of course, sorry, I'm because nobody's asking questions, I thought I'll interrupt. Like, you know, they don't allow mental health assessments, like mental health plans to be done via. I think you have to see the person in person. But I think in a way, mental health assessment, if they allow video conferencing to do it, it's a good way of seeing the patient, what the mood is like. You know, you can make so many judgments on. I mean, they say, you know, the face is not there. You can't judge everything from the face, but again, one good way of you know, assessing a person, you know, if you think, you know, the way they are, if they are teary or whatever, you know, you can see the emotions and things like that to match this thing. But whether they'll allow that, I'm not sure. But you know, in terms of abdominal examination, I think you can still do fair few things. You know, if you're worried about musculoskeletal injuries, you can just you know, if there is thigh muscle pain or something like that, you can look for tenderness by asking the patient to you know, do a few things. Maybe even do assessing a back pain. You can do straight leg raise. You can assess back you know, range of motion in back pain. You know, especially if the person is in pain, and of course he doesn't want to come to the surgery, but he has got acute back pain, then I mean, you can even instruct the patient to do straight leg raise while he's on the bed, and you know, assessing flexion, extension, and you know, things like that. Or the person has rolled over his ankle. You know, you can do a plethora of things, and I think really, I think this is the way modern medicine is going to keep moving. Yeah.
Yeah, definitely. And I think you can do the mental health care plans via video conference or face-to-face for a new one, but they took away the phone item numbers for that one. But I certainly agree. I think, you know, you can do a full mental state exam via video conference, and it's probably one of the easiest exams to do remotely out of all of the systems. So I think definitely can be done, can be facilitated by telehealth.
Thanks, Katie.
And Katie, I'll have you read David's that came through as well.
Yes, I was about to, can you read that question, Katie? So just David said that he is in the hospital. Has anyone done examinations that they've taught patients have led them to health anxiety? So, for instance, getting them to check for edema, and then they getting fixated on these things and checking themselves regularly. So we're using ED, home blood pressure machines were a big source of anxiety for patients. So wondering if we've found a similar thing, because we're obviously putting it in their hands to examine themselves about every lump or bump they might worry about.
Yeah, that's actually a really interesting question, because I've definitely got my fair share of patients with home blood pressure machines who do test their blood pressure probably a bit too religiously and bring in, you know, massive big spreadsheets of readings. So I think health anxiety is going to be an issue, telehealth or no, and I think I know I see that a lot for women, particularly with breast exams. So women who will you know, palpate their breasts quite frequently, get worried about sort of every little lump and bump, and come in for review. So I think that health anxiety will be there irrespective of whether they're being, I think, taught certain physical exams or not. But it's definitely a good point, and yeah, I might definitely see that with the blood pressure machines for sure. Yeah.
And just another comment, just in regards to your study was based on registrars. So I know with the telehealth, I know my patients really well. I speak to them on the phone. I know if they're sounding good or not with the video. I know if they look good or well or not. That would have been a real challenge for registrars that don't know the patients at all. Was there anything about that sort of discussed in the study?
Yeah, well, not in our study in particular. I think in the qualitative study last year, that did come up, of that difficulty and I guess building rapport with patients, particularly if the first time you meet them is over the telephone, you can't even see them, they can't see you, they have no idea what you look like. And if you have a few consultations that are all phone, it's very hard to build up that relationship with the patient. And that was something we saw in the literature research as well, both here and overseas, that when patients were asked to kind of evaluate telehealth or how satisfied they were, a big thing that came up was that they didn't feel connected to the doctor. They didn't feel like they were listened to. They were kind of missing a lot of those like empathy cues that we can give in a face-to-face consultation. So that was something that was quite interesting that came out of that. And I think with video conference, we could get around that a little bit because we can still kind of see each other. And for me, I found, because I'm wearing a mask still every day in the clinic, when I do a video conference with patients at home, they're like, oh my gosh, you're not wearing a mask. I can actually like see your face. And, you know, we can kind of actually almost interact a little bit better by video conference than face-to-face, which is interesting. Something I just thought of too that I thought would be a good point to bring up with telehealth as well is one thing that came out in the literature was a lot of privacy and confidentiality concerns. So like people being on speaker on a phone call, but being quiet in the background and not knowing that that person was there, which was kind of a big concern for a lot of doctors and GPs about patients who might be in sort of domestically violent or abusive relationships. And it's at least by video conference for the most part. You can see people in the immediate background. People can still stand off screen, I guess, but the benefit of having the camera on is you can't have someone sort of right next to the phone sitting there quietly, kind of unknown to you. But another thing that came up was in some of the interviews with GPs, they were concerned about, well, what if I'm being kind of recorded during a video consultation, or what if I'm being recorded via a phone consultation by patients or by patients' relatives? So there were a few things that came up there, and I think that's one of the benefits of using the like a dedicated telehealth software or platform, is that a lot of them prevent sort of screenshots or screen sharing and that kind of thing. But obviously we can't prevent a patient getting up their phone and filming something. So I think just having some awareness of those issues whenever you're doing video conference. And since I kind of came across those studies, I've started asking the patient when I do a telephone call, now, is anyone else here on speaker with you today? Is anyone else around you that might overhear this conversation, so that I can at least document who's present and make sure the patient is okay for that person to be present before I start talking. Because that's something previously with when it was first rolled out that I wasn't really even thinking about as part of my telehealth calls.
Can I make a comment on that?
Yeah.
Because I've been teaching domestic and family violence to GPs as a sort of post-retirement job, zooming into practices all over Australia, I might add. The beauties of telehealth, it's really good. For Uni of Melbourne project it is. And we've had quite a lot of talk about telehealth with patients in those situations. And generally, so I work always with a family violence specialist. So the two of us do the teaching session together. And we work with the practice nurses and GPs and the front desk for part of the time too, because they often observe a lot of things. But with telehealth, mostly the family violence specialists don't prefer it. They prefer us to do those consultations face to face because of that privacy issue. But they have said that sometimes it's unavoidable, you know, lack of transport or, you know, weather conditions. I did telehealth with someone in Dungog during floods, and they were stranded there. There's no way they could get down to my practice. So, and in that case, they have suggested that you establish some sort of key phrase or sentence that we focus on women as victim survivors, but of course men can be too. So the key phrase could be something like, I've got to get the washing off the line, or I've just got to go and check on their dinner, something innocuous like that. And then that you as the doctor understands that this person is not feeling safe for some reason. It could be that the perpetrator has walked into the room, but it could be also that children who could understand enough of what's going on have walked into the room and they don't want to continue that conversation. So I just thought I'd mention that as a learning that I've learned from doing those teaching sessions.
Yeah, definitely. Thanks, Dimity. No, that's a really good point. And I think particularly for those patients who we know well, we can have those kind of code words or key phrases to make sure that they're safe, definitely.
Any other final questions? That was fantastic, Katie. I wish I feel that we've all thrown the deep end with telehealth, and yeah, that was great information. Certainly, with those statistics, I resonated a lot with it in our practice in terms of percentage of telehealth, percentage of video calls, problems encountered, and also the benefits as well. So it's great to see it.
Georgia, Jack just wanted to hop on and ask a question as well.
Hey guys, sorry. Hey Georgia, hey Katie. I'm a Red Jet Point player. I just couldn't unmute myself for a while. So anyway, I wanted to make a comment on that point about what it's like for registrars at the moment. We've actually started phasing out telehealth at our practice because it's quite challenging managing patient expectations. So I'm a new registrar to the practice in GPT-1, and because I have lots of availabilities, people have expected that they can have their care done via telehealth, even though I've never met them before. And so I think there's our policy now is, unless it's a script that the same doctor has written before or the patient has COVID, we're not doing telehealth, because you know, I've gotten things like, I've got a sore testicle, it's 10 out of 10 pain and I've vomited this morning. But I don't want to come in because my child's like a little bit sniffly, and yeah, or I've got big red puffy eyes and swelling around my ears, but I can't do a video conference today because my camera's broken, and I don't really want to come in. And so we just got into these situations where we felt medico-legally it was too much of a danger to take on those patients via telehealth. So I don't know if that's other people's experience, but it's probably one of those new things where, you know, they're booking in with the doctor of the day who has availabilities, and that's just me because everyone else is booked out. And then their expectations is that, you know, I know all of their history, know them in and out, know all their medications and nuances. So that's definitely been a challenge of telehealth in the modern era.
Yeah, that sounds really, really challenging, and I can definitely relate to your experiences as well, where I've had patients calling up with things that were clearly very inappropriate for phone consultations. And I know our practice struggled for a really long time thinking about how do we manage this, and initially we talked about, well, do we have a triage service with reception or the nursing staff to try and determine who's appropriate for phone or face-to-face, but then the I guess the burden of that workload has to fall to someone, and it also relies on the patient being I guess happy to disclose what they're calling up about to a reception or nurse team member. So it's really difficult. I don't think we haven't still perfected how to get that to work well for us as a practice, aside from, I guess, training up our regular patients about what's appropriate for telehealth, what isn't. But it's great that your practice is being really supportive in terms of putting firm boundaries on that, because I think, like you said, for someone who's never met the patient before, that is a really, really tricky and almost dangerous kind of position for you to be in. So I think that's great that your practice is supportive like that.
Yeah, it's just I find it really interesting from a systems point of view about how practices, as you say, triage those kind of things whilst maintaining confidentiality from receptionists and that kind of stuff. Yeah. But it was a great presentation. Thanks.
Thank you. Thanks. All the best with your training. All right. Well, I better duck off my first patient.
And that was great insight, Jack, from the registrar point of view. And yeah, I think that your practices tackle it very well. It's a good little solution there. So, and it's a good reminder for us supervisors as well to keep an eye on registrars and making sure they're not getting swamped with inappropriate telehealth calls. So great. Well, I'll hand you over to Sydney to do the wrap up for us. But thanks everyone, and we'll see you in 2 weeks' time for our next exciting session.
Thank you everyone again for attending. Katie, it was a great session, and I guess I'd say as a client, I guess someone that goes and does telehealth, it's really interesting as well to see the other side of the story. So thank you so much. When we exit out, the questionnaire will come to you for your evaluation, and we will select another Lucky Door prize next fortnight, where we have Dr. Ian Charlton. He is presenting Georgia, I think, what he's learned in 40 years off the top of my head.
So in terms of the difference between COPD and asthma and after 40 years, it's still difficult. And it will be a panel discussion with Dr. Chrissy Gibbs and our registrar, Dr. Kelly Hawkes, and I'll be in the background as well. And hopefully I'll figure out the audio too by then.
I know, I'll have a chat to you offline about everything. And yeah, can't wait to see you guys in a couple weeks. Have a good day.
Thank you.